Well, we really are having a crackingly good session. Our next speaker, Michael Toolis, is a senior registrar in intensive care at Frankston Hospital, and Michael's going to be talking to us about his survey of airway management practices in Australian and New Zealand intensive care units. Thanks very much, Michael.
Thank you. Right. Thanks, Tom, for having me. It's a really huge honour to actually get to speak and present this study. So I'm Michael Toolis. I'm from Frankston Hospital. And I've put together this work with Ravi Tirupati, who's here in the audience, Cam Green, John Botha, and Ashwin Subramanian. And we've been working on the Australian and New Zealand ICU Airway Management Survey. So I think everyone in the audience would agree that intubation and airway management is a pretty core component of intensive care medicine. We'd all agree that it's pretty complex, it's risky, and there's important and substantial patient factors, staff factors, and environmental factors at play. As well as that, there's often a perceived and a real sense of urgency. But despite all that, we and our patients and our community expect us to be experts and to have good outcomes all the time. But I've had this feeling, and often things do go wrong. So I think I've seen, and probably most of you have seen, severe hypoxemia in the peri-intubation period, aspiration, failures to intubate, multiple attempts at intubations, and unfortunately, we see cardiac arrest and long-term brain injury. People have studied these problems with ICU intubations, and retrospective data suggests that there's about a 2% overall cardiac arrest rate during intubation in intensive care. Severe hypoxemia is occurring in up to a quarter of patients, aspiration 2.6, and we're having a failure of first-pass success about 10% of the time. The landmark study on airway management in intensive cares and throughout operating theatres is called the NAP4, which was produced by the Difficult Airway Society and the College of Anaesthetists in the UK, published in 2011. This looked at all major adverse airway events in the United Kingdom. And by major adverse airway event, what they meant was important things like death, need for a cricothyrotomy, and long-term brain injury. Scary things they found was that you're 50 times more likely to have one of those events happen in an intensive care unit compared to an operating theatre or even an emergency department. What they also found is that capnography was rarely used when things went poorly in the intensive care. About Christmas time last year, there was a response to the problems in the UK, published in the BJA. And this is guidelines for the management of tracheal intubation, specifically in the critically ill patients. This was produced by the Difficult Airway Society, the Intensive Care Society, and the College of Anaesthetists in the UK. It's different to prior DAS guidelines in that this is specifically for critically ill patients in our intensive cares. So with all this with the importance of ICU intubations, all the doom and gloom, the scary statistics from NAP4 and new guidelines in the UK, it got me thinking, what are we doing locally in Australia and New Zealand ICUs? Do we need our own local guidelines to reflect our own training? And do intensivists need ongoing training in airway management? So I thought a good way to try and look at this question was to study it. So our objectives were to characterise current intubation practices in ANZ ICUs, to investigate whether or not there is support for the formation of local ANZ ICU intubation guidelines, and to investigate whether or not there is support for mandatory ongoing airway management training for fellows of the college. Our methods, survey design started in about February. We piloted the survey in the Department of Intensive Care and Anaesthetics at Frankston Hospital. We received some useful feedback from that, made changes. We then developed the Survey Monkey instrument in about March, April. We had our ethics approved locally in April. I then approached ANZICS to see if they would be kind enough to actually disseminate the survey to medical members, and they were kind enough to do that. And the survey went out in early June and was open for a month. Since then, we've been working on statistical analysis, and we've kept it very simple with descriptive techniques, interquartile ranges, means and medians. This is a diagram which summarises our participant recruitment. So ANZICS had 756 medical members. We had nearly a 27% response rate. We excluded paediatric responses, and when there was clearly incomplete responses. Some of our responses had an age and a location, but nothing else. So overall, we ended up with a 22% rate of useful data. And what's important to notice as well is that with ANZICS, there was no ability to actually delineate the number of paediatric and adult intensivists, so our response rate may actually be diluted. This slide summarises our demographics. Importantly, nearly 40% of our respondents were from Victoria. Most were males, most were aged in their 40s, most were consultants, and most worked in tertiary intensive care units. It's interesting that about 17% still work in clinical anaesthesia as well. Volume of practice was one of the first things we looked at. So we asked respondents, how many intubations do you personally think you perform per annum? And the number we found was 10. We also asked how many intubations do respondents supervise per annum, and it was 20. This is similar to work done by Brewster's group. We then asked about training, and I wanted to find out whether or not respondents were familiar with guidelines specifically for intubating the critically ill. And interestingly, 40% of respondents were not. Of the people who were aware of specific guidelines, they did mention the new DAS guidelines. We also asked, sticking to the theme of training, we also asked about whether or not participants had actually taken part in any formal airway training in the past 3 years, and 48% of respondents had not taken part in any formal airway training. Of those who had completed training, it was mainly people who were actually teaching on courses and trainees who were doing clinical anaesthesia training time. Drug preferences, I don't think it's a huge surprise that propofol was the number one on preferred induction agent, nearly 2/3 of respondents. Ketamine and midazolam, fairly similar results. Rocuronium came out as the most preferred paralytic agent, and fentanyl was the number one used co-induction opioid agent. I was particularly interested in cricothyrotomy preferences, and as these graphs here demonstrate, 57% of people prefer the surgical scalpel bougie tube technique, and 30-odd% are preferring the needle technique. And I think this is really interesting because the DAS guidelines for the critically ill and for the operating theatre explicitly are saying we should be using the scalpel bougie technique. It's a hot topic, it's debatable, but they are suggesting that. We surveyed a whole heap of different airway practices, preferences, equipment availability, but I've just collected here what I think are some of the most topical and important ones. So starting on a brief explanation of this graph, in that green is when a technique or a device is always used, and red is when it's not used, and the colours in between, as you can imagine, sometimes used, etc. Intubation checklist, explicitly recommended in the DAS guidelines. It's only being used always, about 45% of the times. Of course, that is debatable whether or not it should be done, but that's what's happening. Apneic oxygenation is being used about 12% of the time. Cricoid pressure is being used always by 8% of respondents. And again, this is the DAS guidelines are saying we should always be using it. Of course, it is debatable. Continuous waveform capnography is being used always by nearly 90% of people. That might suggest that there's some room for improvement there. Our primary outcome was to answer this question. This is a question we posed to survey respondents. Do you believe that having airway management guidelines, specifically for the critically ill patients in ANZ, would improve safety and quality of intubations performed in ICUs? And in the light green and the dark green there, you'll see that 61% of our respondents agreed or strongly agreed with that statement, and that 8% of people disagreed. We also asked, do you believe that airway skills training should be included as a mandatory CPD requirement for fellows of the college? And in the light green and the dark green, you'll see that 80% of survey respondents that we had agreed or strongly agreed with that statement, whereas 4% of people explicitly disagreed. So some of the strengths of our study, it's an important area of ICU research and practice. It's the first study to address whether or not there is support for our own local guidelines. We gave an opportunity for all ANZ members to participate, regardless of state, size of unit, whether or not you're a trainee or a consultant. And it was, open to both consultant and non-consultant staff. Important limitation is obviously that it's a survey. We had a limited response rate. That said, most of the surveys that are going out to people at the moment that are published in the ICU literature are giving about a 20 to 30% response rate, and that might reflect how busy people are. There's also the risk of respondent testimony. Are people telling the truth? Is there recall bias? So some of the key messages that I've taken from this is that intubations in the ICU are complex and they can be risky. There is some support that exists amongst our respondents for the formation of local ANZ ICU intubation guidelines, and our respondents, the data would suggest that stronger support exists for mandatory airway management CPD for fellows of the college. So some possible future directions is that we may see an ANZICS or a CICM Airway Special Interest Group or a committee. We may see the role of an ANZICS or a CICM Airway Management Guidelines. We might ask the question, is there a place for mandatory ongoing CPD? And how do we actually logistically achieve this? It's all well and good saying, yes, we should, but how do we actually do it? Is there a role for ongoing airway management registries at a departmental and a state or a national level? And then is there a role for actual ICU airway leads, which is recommended in anaesthetic departments in the NAP4 and is happening in the UK? Here's some of the references. So thank you very much for listening.
Thank you very much, Michael. We can now take some questions.
Michael, you know, one of the things that I've noticed over my career is that doctors nowadays are much better at collaborating with each other than they used to be when I was a junior doctor in the UK. You know, people just felt that they were jack of all trades and could do everything. And it seems to me that if we've got people who are only doing 10 intubations a year, and we've shown that this is the group of patients who have the highest risk in terms of airway management, we should not be doing it. There are other people in the hospital who do hundreds of intubations a year. Why are we doing it at all? Should we get the anaesthetist to come and intubate every case who needs intubation in the intensive care unit?
Thank you for the question. That's obviously a pretty, it's a hot topic. I'm not sure what the answer is. I think there's people that are wiser, more clever than me, but I think there's a role for intensivists to be doing intubations. I think, although the actual personally doing 10 intubations a year doesn't sound like a lot, I think the cognition that goes on there with supervising and extubations, it all ties in nicely. And I think intensivists should be doing intubations, although I don't have good evidence to really support that. But I think there's a role, and I think the founders of the college would agree with that as well. And that's reflected in our training as well. But there's very good reasons that are against that.
Any other questions out there?
Yeah.
Great.
So you mentioned that a lot of the failed intubations happened in intensive care rather than ED or theatre. Do you think that is because of the equipment that they use in those environments? So do they have a different... Was there any information in regards on what equipment they used, like CMAC, for instance, or did they use a laryngoscope or whatnot?
So I think what you're asking is why is there worse outcomes in ICU, and is it about equipment? I think the answer to that, what the literature and the expert opinions suggests, is that it's really complex. There's more to it than just what toys you have available. So there's patient factors. So I think most of us would agree that a fasted patient having an LMA for a knee arthroscopy is probably a lot safer, starting straight off the bat, than a patient with respiratory failure and delirium in ICU. So patient factors are a big component of why patients in the intensive care might have a worse outcome. Of course, volume of practice. If we're only doing 10 compared to someone who's doing a few hundred a year, that's an important part. People have looked, there was a study by Gatward about 5 years ago which looked at availability of equipment. And there was a study in the BJA looking at the availability of video laryngoscopes in the UK. And certainly in the United Kingdom, a video laryngoscope like a CMAC is only available in about 64% of intensive care units. Our data has shown that it's available in about 98% of intensive care units and used by everyone first line about half the time. So to answer your question, equipment is a component. I don't think it's the be-all, end-all. I think it's patient factors, training, team factors, and equipment availability.
I think I've got this right. I come from a small private hospital, and I can tell you that I did more intubations in my junior year as a registrar than most anaesthetists do in their lifetime. They're really wonderful with a laryngeal mask, to the point where they put patients upside down in a lobotomy position for several hours with such, and think that they're doing very well looking after the airway. We pick them up.
Yeah. Thank you.
Ben, Michael, I might just ask you a quick question there. Did you think that you could complement the survey by surveying the anaesthetic population? Because, you know, we're saying the anaesthetists are doing a couple of hundred intubations a year.
Yeah, I agree, totally. So my experience in the anaesthetic world was a different patient, a different animal, very different to the intensive care patients that we have. I think it's a great idea. We're keen to do that. We're planning something at the moment, looking at the emergency department population, a similar study. But I think it would be very interesting to see what anaesthetists are doing, what their understanding of critically ill intubations are, because I think we may see a gap there. I think
and you might not find that there's several hundred per year. You might find there's more like 50 or 60 intubations per anaesthetist per year. Yeah, we got Jeff.
Yeah, quick question. When you conduct a survey, you have to be very careful about how you phrase the questions, because you'll often end up getting the answers that you want. And for example, the question about do you think it should be mandated for CPD presupposes that the answer to this is actually CPD, but it may not be.
Yes.
So how would you go about trying to do a survey without loading the questions, so you end up with a much more granular answers from the community? Yeah,
I would say with great difficulty. So we actually, that's the honest answer. We penned these questions and then we piloted them to try and minimise that. But I think it's just often it's difficult to completely eliminate that factor. If you want to ask someone a question about a specific thing, you have to ask about the specific thing. So we made an effort. We piloted the study. We sat around as a group, changing words to try and not plant thoughts into people's minds. I think that's really all you can do.
Thank you very much, Michael. Thank you.
Thank you.